Hi, I'm Jeff Holden. Welcome to the Nonprofit Podcast Network. Our purpose and passion is to highlight a nonprofit organization in each weekly episode, giving that organization an opportunity to tell their story in their words to better inform and educate the respective communities they serve, as well as provide one more tool for them to share their message to constituents and donors. Our goal is to help build stronger communities through shared voices and to both encourage and support the growth of local nonprofit organizations through podcasting. Thanks to our founding partners for their foresight in helping us transform the way conversations start. CapTrust, fiduciary advice for endowments and foundations. Runyon Saltzman Incorporated, RSE, marketing, advertising, and public relations creating integrated communications committed to improving lives. And Western Health Advantage, a full-service healthcare plan for individuals, employer groups, and families. Affordable health has been a topic of conversation for quite some time now. How do our underserved populations get the proper health care they need? How do their children or elders get fair and equitable treatment when they may not speak the language or are challenged simply to find housing, or worse yet, food? We all know the healthcare system is challenged, and we recognize not everyone gets their needs met for a variety of reasons. So when you don't fit into the appropriate space to belong to one of the corporate healthcare plans, when you're an immigrant working to simply get settled in a new country and something happens that needs immediate attention, what are your options? Add in the fact that you're in a rural community, work on a ranch or a farm, and don't have simple transportation, and you can see the challenges that most of us never have to experience. Fortunately, there are programs implemented to support this group of people with the intent to minimize the challenge and improve the education and proper health maintenance to prevent a small issue from becoming a possibly life-threatening one. In this episode, we're going to be talking about one of the solutions that is working, evidenced by its growth and the impact on the communities this nonprofit serves. I'm speaking with Greg Stone, CEO of Peachtree Health. You may recognize them as a clinic and a shopping center, and that would be appropriate. But as you're going to hear in this conversation, they are so much more than that. How they serve, who they serve, and the services they provide will amaze. Their work is not so simple, and their funding can be equally as challenging. But the need for what it is they provide the communities they serve is unquestionable. Greg Stone, welcome to the Nonprofit Podcast Network.
Thank you. Glad to be here.
We're excited. This is the first healthcare program or healthcare system or healthcare entity, I should say, that we've had on since our inception.
Well, it's about time.
Right. So tell me a little bit about how Peachtree Health came to be.
Okay. Peachtree, as a community health center, kind of had its seed, much like many other health centers in America, which is coming out of some other organization. In our case, it was the counties. So Yuba and Sutter counties, where we started divesting a lot of their services in outpatient clinics that were traditionally county-run. And the health center movement created a new vehicle for that and be able to create a new nonprofit and move it into a different business model. Still sustain, maybe grow services in the community, but take it out of county control. So we did. So that was back in 91, so over 33 years ago. Mm-hmm. Peachtree took over, Yuba County kind of divested their clinic, put it into the Peachtree Mall there in Marysville, got our illustrious name, Peachtree Clinic. And
so it did come from the mall because you were a mall-centric.
It was because we were in the center. There was, after the mall flooded, they tried to reinstill businesses, and the county put a lot of services in the mall at that time.
Boy, what goes around comes around, and now we have clinics going back into malls again.
That's right. Well, you got to go where the people go, right? So so we started there, and eventually they became their own nonprofit and applied for a federal grant to become a federally qualified health center.
Let me ask you, you've got Rideout Hospital up there.
Correct.
The differences between clinic service versus hospital system as a consumer. Why would I just not go to the hospital, or why would I just not go to the hospital and stay at the clinic?
Yeah, it's a fair question, and I don't think the answer is the same in every community. If you look at most hospital systems now, they are focused on traditional services that require some sort of inpatient stay, so you're staying in the facility, or some sort of traumatic entrance, right? There's an emergent need that couldn't wait for some other scheduled event. So through an emergency department, through an ambulance bay, you're going to come into the hospital. So they're treating very acute situations, things that need long-term care or surgery, et cetera. What we do is really the traditional family medicine and outpatient care. We want to be your family's doctor. So we want to be in front of that. We don't compete with the hospitals in that way. Although hospitals will have often outpatient clinics that will have doctors and services in different communities or in the region around their hospitals to help feed kind of specialty care services to themselves and kind of create better contact with their community. But we don't really compete in that way. We are very reliant on the hospital system and all their specialists, and we refer patients in and out. We follow patients in and out of the hospital that are our patients. But if you need an X-ray, you need surgery, you've had some traumatic injury, you need to go to a hospital.
Sure.
Everything else we try and deal with outside the hospital, and that's mostly a function of convenience and cost, really.
I think that's important for people to understand too, that it is a collaborative effort.
Yeah.
You have to share services. There's things that you just can't provide, otherwise you become a hospital.
Yeah,
with a full-blown facility and surgical capability.
You have we have a different slice of the pie, right? We overlap in some regions, but we generally don't compete. We augment each other, right? So we have services that they uniquely don't offer, and yet our patients often need to those advanced care services that move into the hospital system and back and forth. So for the layperson coming to America or moving into a new community, it's difficult to know, like, how do I get healthcare, even defining what that healthcare is. So traditionally, if you're confused, you go to the hospital, right? And
ER.
You go to the emergency departments, and they're notoriously impacted with pretty much unnecessary emergencies,
right?
Because there's no other clear avenue in the community to do that, either because they don't have the right healthcare coverage, or they don't know the area, or it's the off hours where their normal outpatient services aren't open.
Yeah, or even no healthcare coverage.
That happens.
Yes.
Right? Or it's very confusing even how to utilize your healthcare coverage. All these ideas of being in and out of networks and being assigned and unassigned.
PPO, HMO, concierge.
It's a very complicated business to someone who just needs something done.
You just said the key word there, business.
Yeah.
Let's touch on that. We were talking about it a little bit prior.
Yeah.
Before we got started. Hospital systems, healthcare as a business versus as the right thing for the community.
Yeah.
Not that they are distinctly different, but there's issue there.
There is. I think fundamentally, America has continued a journey of trying to determine what healthcare should be for its citizens. We've really gravitated towards a business model where providers of all sorts of traditional healthcare are business owners, and they contract with payers, and they provide services for fees, and these transactions go on, and so some make it, some don't. Some are successful, some aren't. Some are more high quality than others, but it's a business, much like a restaurant would begin or fail. So that is okay, but it doesn't really solve the problem. The reality is that the vast majority of the healthcare that we deal with, you think about Medicaid and Medicare, think about the veteran services or disability, all these things. These are government-funded healthcare programs. They're not insurance. These are programs. They're reimbursements. And there's a lot of barriers around. There's lots of boxes around those services, like what you can and can't do, where you can do it.
What you can and can't charge.
You can't play with the rates, right? They are what they are. So when you are trying to solve a problem in healthcare that is a fixed payment model, like a Medicare or Medicaid, in a world of escalating costs and changing needs, it's really difficult to run a business in that model, right? So if you have
You
any
can't
other
control
business,
your expenses.
well, you can, or even the services that you offer,
Yeah.
right, or where you offer them. So if you are running your own business, you can determine that this item is selling more than this, or this food item isn't ordered as much as that, and you can change your food prices, you can change your ticket, you can add more people in the day. These are things that we largely can't do in healthcare. A lot of our delivery requirements and the cost of them are very fixed. And our game in the business is to figure out how to survive in that box. And it's increasingly difficult. So there isn't an area in healthcare that isn't struggling right now. We all have
We're seeing hospitals close, which you would never have thought it could happen.
They're very difficult businesses. I mean, it has a different business profile than the outpatient service that we operate in, but it is such that you don't know who's coming through the door. You can't control what is about to happen to you. You have a suite of services you have to keep ready all the time.
Yeah.
And if the wrong payer comes through or too many of a certain type of thing come through, it could really decimate a very fragile bottom line.
Yeah.
And of course, healthcare is one of those rare services that can't be automated, and it just can't be replicated without people. It's a very people-forward.
And we hope so.
We do, but it is the vast majority of the cost of healthcare, and increasingly, certainly after the pandemic, a career path that a lot of people are really taking a second thought about. And the few people in the game can entertain a much better salary, much more than we can charge for, right?
Yeah.
So that's the pressure everywhere. It's just a traditional supply and demand.
Yeah, I've seen that in particular specialties and specialists where you can't find them. They don't exist. And the few that you do find, if they're good, you're going to pay exorbitant amounts just to get them to service the community.
Yeah, it is traditional market pressures of supply and demand that we've seen coming for years, that there just wasn't enough providers and allied services to cover our pending need. But the pandemic really flushed out all the people who were on the fence. It pushed people into retirement that might have had a few more years. It took people out that were just starting. It made people change their mind about how much they want to invest in that.
Yeah.
And the few people that are out there now really command a lot of power in the market.
As a clinic, do you have a little bit more nimble step as a result of that, because you don't have this massive facility and acres of property that gives you the ability to maybe shift a little bit or pivot based on what you're seeing as need?
Not really.
Okay.
I mean, and we all have our fixed costs. Our plant costs are very limited relative to a hospital or a specialty service. But it is commensurate with our reimbursement rates. We are seeing primarily Medicare and Medicaid patients. 85% of our patient base are paid for by these government programs, and they're very fixed costs, and they're closely managed, right? As we talked about, the government looks at this as being, not a right necessarily, but more of a covered service to a certain point. And so there's a very firm line about where it begins and ends, how often you can utilize it, where you go. So when we see things change in the community as far as populations that are underserved, communities that are growing and don't have access, it's really difficult to pick up and start something new there. There's not a lot of profit left to simply go build a new facility, open new services, expand into those areas. Our model is still really focused on treating people after they're already sick or injured. It's a treatment program, and we are paid a fee for every time we treat somebody. The reality is that healthcare is much more than just treatment of disease and injury, but we have no way to monetize that. Right? The only way we can make money is to see people who have a need.
Right.
And by then, it's already pretty advanced. It's expensive. It's going to start impacting the whole continuum of healthcare when we might have prevented that somewhere upstream. with housing, with education, with food, with behavioral health and substance abuse treatment, all these things that impact people from having a healthy life. But there's no reimbursement in our fee-for-service model to do that, right? Unless you come into a hospital, unless you come into a licensed clinic, we can't bill services, and those are uncovered. But that's really, I think, the magic wand moment is what is the solution? It's finding a way to monetize the improvement of healthcare in your community without turning it
almost
into
like
this.
supportment of wellness to
Yes, it's
maintain.
it's a generational change.
Yeah.
I mean, it's a commitment that's going to require, really many different political office elected officials and a long-term view of it. We have a lot to undo, but just taking care of people who are sick is unsustainably expensive, and we're not really gaining on it in most cases.
We got deep quick.
Yeah, sorry.
So
yeah,
no,
sorry.
but I think that's really helpful to understand. Yeah. Let's take a step back. You've got multiple locations in the Yuba County area, Marysville, Yuba City, Chico, and Sacramento.
Yeah.
Who is the community you serve? Who do you see most in the clinics?
So, by race and ethnicity, those are pretty varied communities, and we're spread out through those communities. But as an aggregate, we are a reflection of the community. So, most of those communities would be considered white, non-Hispanic, followed closely by, Hispanic and all related. So then moving next, it's into would be considered an Asian, whether that comes from India or peoples from Southeast Asia or the Far East. But increasingly, it's difficult to put a finger on it because we are becoming such more of that melting pot. And so we see more and more people identifying as more than one race. So this idea that some like healthcare is related to your race or ethnicity isn't necessarily wrong, but it's difficult to really verify any longer. So our business, since we take care of people who primarily don't have access to large commercial and very expensive healthcare, we take care of those communities that really reflect traditional poverty and neglect. In California, 40% of Californians are on Medi-Cal?
Right.
It's a stunning number, over 15 million people. And in our communities that we serve, the Sacramento, Yuba, Sutter, Butte County areas, anywhere from 25 to 29% of them are on Medicaid. It's a big swath of our community. These are people making just over $20,000 a year to qualify for Medicaid. That's pretty impoverished in California.
Right.
They have a lot of needs, and healthcare is typically one of them.
In those areas, because you were in a highly agricultural area there, with a Sikh influence and certainly Hispanic influence, do you see a lot of the migrant population?
So we have traditionally seen many of the same families come through in
generationally.
Yeah, somewhat, as far as our records go. But what I've seen in those communities is a decrease in what we would consider truly migrant farm workers, mostly because I think of the transition of the type of agriculture that's going on. They moved away from a lot of the people-dependent fruit crops, the peaches and the apples and the pears that required people to pick them, and they were seasonally there, and people would roam through and do that.
Yeah.
And moving more into nut crops and rice and things that are very mechanical. So we see more resident farm workers than we do migrant in our area. I think it's mostly a reflection of the change in agriculture.
That's interesting. We used to have a small business up there.
Yeah.
And I remember they would bring boxes of peaches.
Oh, yeah.
And they'd be sitting there for the people. It was a radio station, and then jocks would all get their peaches when it was peach season.
Yeah.
Hence, Peachtree Mall.
Absolutely.
And even your
it's
name.
Big business.
Yeah.
Big business. And there's still some peaches there, but it's an expensive fruit.
Yeah.
And just like it does with wine or anything else, those varietals change as farmers look at what the market bears, and it's difficult to get people to buy beautiful peaches. So they move them into almonds or walnuts or
Sure.
something that's a little more marketable.
Is there a particular service that you see more prevalent than others?
Well, we are at our core a family medicine provider, right? So that's full scope adult care as well as pediatric and adolescent care. So that is really the vast majority of our services. The traditional go see your doctor, whether that be for wellness or whether that be for illness or injury. Your traditional family medicine doctors and nurses and allied practitioners are all our bread and butter. Now, saying that, there's a lot of overflow that now that we have you're also pregnant. And so we have an OBGYN program, right? And you also need dentistry, and you also need behavioral health, and you also need your eyes checked. And so over time, we've kind of grown from this core of just being the family doctor into more of a full service medicine for a population of people who don't have access to many of those. It's difficult with Medi-Cal to walk into most communities and find someone who will, an optometrist who will take your insurance and do your exam and give you glasses. Or if you're pregnant, where are you going to find a doctor to take care of you? So we have, over time, found ourselves becoming more specialized and insourcing a lot of the things that were traditionally outsourced, mostly because we have a constant demand of that, and it doesn't make a lot of sense to send people someplace else. It's become a much more integrated program, and that's been our focus. Is once you become a healthcare a customer of ours, and you start to get the benefit of all these services. So you may come through a door because you needed some dental care or you needed your vision checked, and now that we have you, we can introduce you to full healthcare, and we screen you and we assess what you need and bring you into healthcare. And I think it's a beautiful whole person care sort of model that really benefits the people that come to community health centers, where most private providers are very specialized in just what they do, and everything after that is probably your problem to go find, and that's increasingly difficult to navigate.
Well, that's a beautiful opportunity, though, because not only for you with the breadth and scope of service, because it helps offset expense, because some of those are more expensive than others.
Yep.
But the other part of it is you really get somebody from head to toe.
Yeah.
And once you've got them in the clinic, you now can see the entire body, from eyes to mouth to, organs and everything else, which has to be beneficial to that individual too, because it's unlikely they're going to go from specialist to specialist to specialist. They just won't do it.
Or they can't do it.
Or they can't do it, right.
And so I think you're right. I think this, the way that we've really expanded our capabilities within the restrictions of what we do is to try and fit as many services into those health centers as possible, or refer you to another one of our health centers nearby that do that, or move it to telemedicine, or do a lot of things. So we are constantly trying to figure out where the gaps are in the community. There are communities that we serve that might have good dentistry for Medi-Cal patients or uninsured people, so we don't offer it there. And there are others that nobody does vision, so we have a big optometry. Right, we try not to duplicate services or compete with other providers, but within our system, you have access to everything. And that's a unique part about being a patient at a community health center, is that you do have access to an extremely deep pool of care.
And is that typical with most community healthcare centers?
It is,
okay.
Yeah, increasingly. The more rural you are, the more isolated you are, typically the more focused care needs to be. So it's traditionally just family medicine and few specialty care. But in most cases, even what we consider somewhat rural, some of our largest health centers are in very rural areas, and that's just because that population really does not have access to it. And so we continue to grow and provide that, and it's a way for us to not let people fall through the cracks. We are trying to get people into a culture of care. I think a lot of people growing up in poverty really didn't have a opportunity to think about healthcare as being something that's just part of your day. And most of their experience is either when they're in extreme pain or they're in the emergency department, and that's a lot of bills. That's a lot of shame.
Yeah, let's avoid that at all costs.
Right. So it's something that takes a long time to build. So as people come through the door for something, we try and now introduce them to all the other things that they're available to, and they're typically not aware that all these services are available to them.
You mentioned a couple of things in response to the last couple of questions I want to approach. You have some really neat, novel items, let's say, out there for healthcare service. You have the mobile vehicle for general healthcare, and you also have the tooth mobile, I think it is.
That's right.
If I'm not mistaken.
Yeah, we
Tell us a little bit about those.
So, it's great to have a large community health center with lots of inclusive services available to your patients. But there are still parts of the community that just can't get there. There are still people living in your community that can't access your care through transportation or availability or work or daycare or what have you. So the next step is trying to take core services into communities where the people are during the day. And so our partnerships, like an example being our mobile dental program, has been going on for over a decade, is a partnership with the Marysville Joint Unified School District, the Yuba County First Five, and Peachtree, where we all pool our funds and staff to bring full service dental care to all the elementary schools in the Yuba County area.
See, that's wonderful.
So we are the first dental visit for the vast majority of children under 5 in Yuba County, and we have been for years. And those are patients who typically don't engage with dental care until they're in pain, and then they have a lifelong fear of dentistry.
Right.
This is a way for us
first experience is a horrible
experience.
It
is, and their parents are afraid of it, and it's a whole. You have to break the cycle by having them go to school, someplace safe, have the school endorse and bring them into the clinic, and then we take care not only proactively, but we have a full surgical availability there too, and a lot of education and outreach. And it's a good example of a service where beyond just taking care of the immediate need, we send children home every day with the first toothbrush in their family. That still happens,
That is hard to believe.
And their family,
first, second, third, fourth, whatever grade.
Yeah, it wasn't part of their family culture to have self-care and dental care. It was emergent. They had problems. You'll have problems. People have problems. So, when you think about the barriers to care, just start with they've never had a toothbrush, and no one's ever showed them how to brush their teeth in their language. Or they can't see the chalkboard but never complained, and because they don't take them to the eye doctor because there really isn't an eye doctor, and they suffer unnecessarily with vision loss. So,
and I'm sure it translates to hearing, to
all these things.
You name it.
And so what we try and do is find areas of our community, school's a good example, where they know the children that struggle with staying in school. They know the children that struggle with improving in school or paying attention at school. And oftentimes it's because they're hungry or they have mouth pain or they can't see the board or they don't understand the language. And these are things that just go on without anybody recognizing it. But we interact with the schools for those referrals, and oftentimes bring those services to the school. We vision screen there. We do dental care. We have behavioral health embedded in schools, and try and capture that early, and start to turn that around, make it safe, make people feel like, make these kids feel like there's someone that's listening to them, solving some of their problems, and ultimately setting them up for hopefully a lifetime of trusting healthcare and engaging in proactive healthcare and not just reactive.
And not to mention that also gives them the familiarity with you, with Peachtree as a service that's provided in the community, so that student takes it home, mom and dad get sick, somebody gets sick, gets hurt, whatever. They tend to be the ones that lead because their
it's true
language is better, and then they can navigate the system in some way, shape, or form.
It's very common to have a child referred to us for vision services, for example, and we're the largest Medicaid eye provider in Northern California.
Wow.
And we have services all over these areas, but people are referred to us for eye care, and when the children come in, they bring the whole family because the family doesn't really understand what's about to happen.
Right.
None of them have been to that. Maybe multiple generations are together.
Well, you're here. Let's take a look.
Let's all take a look. Let's all
Sure.
sit down, and these are kind of scary machines. These are kind of dark rooms.
Yeah.
And what are we doing? There are language and cultural barriers to overcome. So we try to take the time to get everybody into the room and have everybody look through what the child's looking through and see what it looks like. And ultimately give their permission for us to care for their child, but also start thinking about, Mom, why don't you sit down?
Right.
Why don't you, and it's not just the vision loss, and I have unclear vision. It's more and more just, eye disease due to diabetes and hypertension and things that are impacting their family that they thought is just something that happens in their family. They didn't know they were preventable.
And who would think, I would imagine, glasses are not unfamiliar. People see it, they watch television, but to think for me, well, it has to cost a fortune. I can't afford that.
It's luxury.
Right.
Yeah.
And it gets us into the next question of funding. We'll be right back with Greg Stone to learn a little more about how the organization is funded right after this message from the people who make the program possible. I was in the media business for over 35 years and had the great privilege of working with Runyon Saltzman, RSE, Marketing, Advertising, and Public Relations. We collaborated on many different campaigns, but their commitment to the nonprofit sector hasn't changed since their founder, Gene Runyon, started the agency. Over many years and many campaigns, Runyon Saltzman has been committed to improving lives by tackling California's most challenging issues. Guided by research-informed strategies and insightful, creative solutions, RSE develops innovative communications campaigns that raise awareness, educate, and reduce stigma in diverse communities throughout our state and beyond. To learn more about RSE, visit rs-e.com.
Hello, this is Scott Thomas with Cap Trust in our Sacramento office. I specialize in working with local nonprofits and associations. Annually, we survey private and public nonprofit organizations across the country to better understand challenges they see in today's environment. In our more recent survey, we heard concerns about proper board governance, mission-aligned investment, and how to implement alternative investments. If you would like a copy of the survey or to discuss your organization, look me up, Scott Thomas at captrust.com.
I'm thrilled to have Western Health Advantage partnering with us as they do so much to support so many nonprofit agencies in our community. As a truly local health plan, you'll find individual and family options, employer options, plans for CalPERS and Medicare Advantage. From medical services to pharmacy, health and wellness support, as well as behavioral health care, Western Health Advantage has a plan that fits what you need. As an employer, for profit or nonprofit business, individual or family, you can find more at westernhealth.com. How are you funded? Because a lot of the people you are dealing with are, Medicare, Medi-Cal, and some sort of social service. And we talked about the challenges of that. Is it just government funding, or do you have access to other sources?
So it's a big bucket, right? So the short answer is most of our revenue comes from billing for services, right? So, we accept dozens of commercial insurances. We accept all patients without the ability to pay for their care. So we have the ability to completely waive their care. We have the ability to give them an affordable sliding fee for their care. We meet them where they're at. So when you think about providing an eye exam, and it's not just I'm billing Medicaid or Medicare, but it's all these different commercials. Maybe it's some out-of-pocket cost for somebody that's uninsured that could pay for it, or maybe it's someone who has no ability to pay for their care. So that our actual cost per eye care visit, it really varies depending on who walks through the door and what community we're working in. But
and the severity of whatever the eye care is.
But and our reimbursement for that, whether we spent 10 minutes or an hour with you, is the same. It's just the way the system works. So over 80% of our revenue comes from that process of just
Reimbursement.
fee for service, right? So I'm gonna bill some program for that care I just provided. Beyond that, we are a nonprofit, so we do have the opportunity to apply for large grants and corporate giving that allow us to provide services that are otherwise unfunded. We also receive a federal grant as part of our designation to help offset some of the cost for people who can't afford their health care.
Okay.
But we overrun that by millions of dollars every year. So when you think about operating a business, any business where any customer can walk through will never be denied, but you are not sure how much they're going to pay you for that service. It could be
that's a
anywhere
rough
from
business.
It could be nothing
Right.
to full price.
Right.
And you have to think about kind of what services you offer and how often you offer them. And it's a difficult part of the business, but the reimbursement is the biggest problem to work within. And it's actually the biggest limitation because it focuses you into areas where you can generate billable visits with patients when really the need might be somewhere else, but it's unfunded, right? And it's one of the traps of healthcare, the way we've designed it. So we do the best we can within that, but there's no way of getting out of the business of seeing hundreds of people a day in a very traditional medicine way.
Tell me a little bit about your healthcare team. How many people do you employ?
Peach will be probably about 280 employees at the end of the year.
Okay.
We are a growing organization right now. We also enjoy long collaborations with other contractors and other service providers that aren't direct employees. So there's many more hundreds of people working on our behalf to do that. But that's clearly our number one cost is people. We're a people business, is people providing services to other people. So their salary and benefits is our increasingly difficult problem to solve.
You mentioned telehealth, telemedicine, and I'm imagining in the channels that you're serving, that could be difficult because they may not have access to a computer or internet or wireless. They do have a cell phone. What percentage do you see starting to gravitate to telehealth in some way, shape, or form?
All forms of telemedicine, whether it be just a telephone or video, audio, really was something that we could not do for money prior to the epidemic. So after COVID, there was such success when the states kind of waived the rights to telemedicine so we can actually reach out to our patients by phone or by computer.
I didn't realize that was the transition point.
They did. Yeah. Medicare had a small window of opportunity to provide services through telemedicine, but it was very defined and difficult to manage. But Medi-Cal did not allow it in most cases. So in this case, they've kept that in place because they saw such a dramatic increase in access, and certainly with people who previously weren't accessing healthcare. Whether they live too far, they never have transportation, they might be disabled, they don't have help, any number of things. So we have really taken a look at that over time and realized that there's a large portion of our patient base who really only want to receive their health care through some telemedicine service. So we've been progressively adding that to our program, starting initially with behavioral health, where a telephone call with your therapist is very therapeutic and very helpful and tremendously more impactful than getting up, getting dressed, going into a community health center and sitting in a waiting room and dealing with your anxiety and your depression in public and all those fears. So we saw a lot of our patients gravitate and stay with telemedicine. We have since really invested in this idea by expanding those services quite a lot in the last 2 years. We now have a large team of physicians who only work in telemedicine. Many of them don't live in the state; they're licensed here, but they live elsewhere. And we have a whole team that just connects people to telemedicine care, both same-day service and scheduled services. And some people who their primary care doctor is remote, And that has brought so much relief to areas of our community we just haven't been able to touch. So it's an area we keep expanding. The telephone still is the main way, to your point. Pulling up an iPad and having an audio-visual experience with your doctor is something that is pretty far out of most of our patients' grasp.
Yeah.
But a telephone isn't. So we have a lot of good interactions with telephones. It's flexible. People can be in their car during the lunch break. They can go in the bedroom at home and have some privacy. Those are access barriers now. And so they've been overcome. So we continue to invest in that. Our mobile services, we have other mobile services that go out in the community that have behavioral health and medical services embedded in them. They also have telemedicine. So you might be in a very remote area. You can still see a specialist. You can still see somebody at the health center, even though your provider isn't on the van that day. We are starting a program of putting full telemedicine kiosks into key areas in our community where people often aggregate, whether it being a homeless support area, a coordinated housing, schools, and then patients can come on a scheduled time and have a full telemedicine visit with us, video and audio. And it really is starting to break down those barriers of, I just can't get there, which is increasingly the main problem to solve for us.
But what a beautiful way to minimize some of the, if somebody puts something off, it only gets worse. If they know that they can make a call, and maybe it's just an antibiotic or something simple that can be taken care of before they get in and find themselves in the ER.
That's right.
They become more and more familiar, I would imagine. They get more and more comfortable, and family members, somebody calls for the other family member, whatever the case may be, to catch it before it gets to a point of...
We send patients home with self-monitoring devices for blood pressure, for blood glucose, and some of those are uploaded directly to our computer every morning. Others they record. And so when we see a problem, we can call them or have a doctor call them and say, hey, are you taking your medication? Or what's changed with your diet? And, you can have the conversation you would have in an exam room.
Yeah.
Patients that don't show for a scheduled appointment in the clinic, they get a phone call saying, hey, we expected to see you at 3 o'clock. And they say, sorry, I couldn't get off work, or I couldn't get daycare, or my ride didn't show up.
Right.
Well, can you talk to your doctor right now by the phone? It's like, sure. And we just get them on the phone. And they get most of the work done, checking in. Is that working?
That's wonderful.
How are you feeling? Did the headaches go away? Did the rash resolve itself?
Yep.
And if they need to come in and they need to get a vaccine, they need to take a test, they can come in anytime to one of our clinics and see a nurse without an appointment. And then now you have the complete visit, right?
Right.
So we're trying to decouple this idea of healthcare only happens in exam rooms at scheduled times. And we're trying to meet people with restrictions kind of where they're at with still providing a high-quality service. And increasingly, it's the biggest growing part of our business.
That's great to hear.
Yeah.
Last two questions. First one's big picture.
Okay.
Money's no object. What does it look like?
Wow. So I think I would go back to that idea of uncoupling your healthcare from the restrictions of your insurance or government program, right? So if you come to my clinic, I can't see you for 2 or 3 things at one time, only one of the things. I can't see you 2 times this week because I can only see you twice a month.
Because that's the way the reimbursement
Because that's
works.
the way the restrictions for whatever program that is.
Got it.
So the best thing would have been that it's hard for you to get to the clinic, but when you get there, you are going to be screened by the nurse. They're going to check all your vitals. They're going to check all your testing. Your doctor's going to have that information before they see you. And while you're there, you're overdue for your eye exam. And also we're going to get you this booster that you're overdue for.
And by the way, you had a cavity the last time we couldn't take care of it on time.
That's right.
So let's get that.
If you can spend an hour and a half, 2 hours with us, we can do 2 or 3 services with you and get it all done and have a full picture of your whole health right now. Like, wow, you came in just for an eye appointment, but your eye pressure is so high, you need to see your doctor, or you're overdue for your podiatrist. That's part of your diabetes care plan. And so we can do it right now. And and we struggle with that, and we try and pick the most important thing for them to come in for, and work it out, and it's really not an ideal way. So if money were no object, I would do the first thing, which is to uncouple the services from these reimbursements and do the right thing when needed. And the next part would be to not rely on this fee for service barrier for reimbursement. And so now I really can have healthcare. I can meet you at school. I can meet you at work. We can really have some robust healthcare. I can provide high-speed internet to your community. I can do all sorts of things that connects you in a way.
For mobile vehicles.
There could be any number of things but I think building more clinics and offering more of that traditional service to just see more visits is a trap. I mean, there's just not enough people to do that long term. We have to find ways upstream to prevent the illness that's impending, right? And a lot of it's just through education, and just access and early screening, and certainly our access. Getting children and adolescents is one of our main focus right now, as far as making sure that they have really good service and really good connections with healthcare, so that hopefully in the rest of their life they seek it out and they don't.
For their families as they grow up, but even for the generation above them that's at home to see that's the benefit that I see. That collaboration with the schools is so huge.
It is
to integrate and start early, especially since every parent has a concern for their child too.
Yep.
And they don't want to see their child in pain, so they're going to be supportive of whatever that is, even though it may be frightening to them because they haven't experienced it before.
Yeah, and they don't know what's offered to them.
Right.
I mean, a lot of people come to us thinking that they have no ability to pay for health care, but California is an amazing state to be in a way of accessing services.
Yeah.
Medicaid is very accessible, and there are a lot of other services around it that are little to no money that most people fall into. The bucket of patients in our communities that is truly unable to be covered by any sort of program is increasingly small. In other counties in California, it is a big burden, but in our region, we've really been able to impact that, and so it's just letting people know it's like this is free to you,
right?
Or this is covered, or
don't worry.
And you can also see the dentist, and you can also see the doctor, and so I think we try and use that idea of whatever door they come through is to now kind of be an ambassador to whole person care and think about this. So if you come in for a dental exam, we screen you for depression. It's just an opportunity we may not get again. And oftentimes, we capture a patient now that didn't know that they can be connected to a therapist.
Yeah.
So we try and couple these things in ways that grab people when they finally do engage, and whether that be at school
and don't let go.
Yeah, and then increasingly we have staff outside of our health centers who are managing those very delicate cases, those people who are transitioning from the hospital to home, or that are always in and out of care or in and out of homelessness. We have people who track and follow them and make sure that they don't completely fall down, and we can get them back. And so, housing becomes something we provide. Food is something we provide. We run our own pharmacies.
Through collaboration with other entities and organizations in the community?
It is, both to ourselves and through others. We work with Habitat for Humanity. We work with all the counties as far as integrating those programs. And it's, from our patient standpoint, I'm hoping it's feeling more seamless as they are in their most vulnerable time.
Right.
That they get handed off really carefully between these agencies, and we get people that are referred up, and we refer people out, and ultimately the success stories happen all the time of just someone who needed a lift. A good example of that is right now one of our big initiatives is to work on the transition of people leaving incarceration in California. There's a large number of people who leave jails and juvenile hall that just fall back into the community without really following on to their health care. So we are entering into a contract with Yuba County right now to receive all patients, all people that come out of incarceration, and screen them, work with coordination of care, make sure they have housing, make sure they have jobs, make sure they have the behavioral health, make sure we continue their health care.
Beyond.
Well, they are Medi-Cal eligible, And the state is really pushing to try and solve this problem. So we are trying to connect them, let them know that we're here. Oftentimes when people go into jail, it's the first time anybody's ever treated them for a disorder. They're often dealing with a substance use disorder that they could relapse with. They have anger issues. They don't have a place to go. They don't have a job. These are all things that we want to figure out and ultimately be a net for them when they leave. So,
and that is done in collaboration with the other nonprofit agencies that recognize those.
And it's the
conditions.
county and Yuba County Sheriff and probation departments. And
that's fabulous.
We all meet together and we case manage these people and find the pockets of the community that need help. We work with foster families and family services. And, these are marginalized people in our community who don't have access or the wherewithal to help themselves. It's a very vulnerable time. But if with a little bit of help and hand-holding, they fall right back into society. They fall right back into care, and they get their kids back. They don't go back to jail. They get healthy again. They quit their addictions.
Right.
That's what we all want. But it's not the traditional model of come to the clinic and see your doctor.
Right.
So finding ways to pay for all that is the challenge right now. Those are the problems to solve. But
the offset is far greater. Finding the solution to that today is far better than the continued issue that would happen, whether it be the crime, the abuse.
Absolutely.
Just all the conditions that happen when that doesn't get handled because it was too expensive to do the first time.
It was, and they were looking at one thing.
Right.
You're incarcerated, right?
Yep.
And they have a duty to do while you're there, but then they put you back out, and you still have a mental health disorder, or you still have a substance use issue, or you still have an anger problem, or you don't have a job or a place to live. And so what are you going to do?
Right.
You're going to reoffend.
Right.
And these are long-term goals. I mean, these metrics aren't something we can measure on a monthly basis. Right? These are societal problems in long-term, but we are now finding ways to find the pockets of people who are just traditionally underrepresented and find a solution for that. And that's what's exciting about this part of healthcare is that that myself and the people that work in community health centers, I think we all firmly believe healthcare is a right. And so when you think about healthcare through that lens, it really frees you up to find new creative solutions. And if it's just a business model, then it really restricts your thinking about what you can and can't do. So I've been in healthcare for over 30 years. I've done a lot of things. I've worked in hospitals. I've worked in private. I've done emergency care. This really feeds me. This really feeds my company's employees. People come to work in this organization and organizations like ours because we make real change, right? We solve intractable problems, and they have an opportunity to go work somewhere else. But increasingly, we're finding the few people we need are showing up when needed, and so we keep growing.
Well, you just brought the opening salvo all the way back, to a beautiful close, because if the person is healthy, the community's healthy, and what you're doing, you've got mobile medical clinics, you've got 200 plus employees, mobile dentistry, eye care, mental health services, and a concentration of where your people need it the most. And you're feeding it back into the community, not only from a health perspective, but from a functional perspective. You're talking about jobs.
Absolutely.
But you're a clinic. Well, that just, I think that screams volumes of where the capabilities are, what the future could look like. And, for what you're doing and how you're benefiting the communities, I applaud you. I applaud you and your team and the doctors and the way that it's being taken care of. And I can see the sincerity in the conversation of how you really want to change this. And we need that.
Yeah.
We need that. So thank you for what you're doing. And
thank you. I appreciate that.
And we appreciate it.
Yeah. It's changed my outlook, the way I look at my community. I wish I found health centers earlier in my career, quite frankly. But it was a great awakening, and when I look in my waiting rooms or see people leaving my health centers, I see representatives from all over my community. It's most healthcare in America is tied to someone's employment, and increasingly that's difficult to get. So you can be well employed and be completely healthcare impoverished. So we trying to have that net for everybody. And yes, we'll see the homeless. Yes, we'll see the incarcerated. And yes, we'll see the people in business suits and coming in on their break from Starbucks and all those things. We are serving the community without any stigma about where you come from. We translate over 20 languages. It's a beautiful thing, and it's working. I mean, I would hold our clinical quality outcomes up against anyone. I get my health care in my health centers.
Yeah.
So it's I think how healthcare should be delivered.
Well, I appreciate, and I see the pride in it, which it exudes.
Yeah.
And it's wonderful to see. I think it can give us all hope that there are solutions, there are conditions that can be met, there are ways to work, and it's collaborative. There's not silos that work. We have to expand into the community. So again, thank you, and I'm so glad you were able to come in.
Yeah, my pleasure. Thanks for having me.
Appreciate it.
Yeah.
I hope you enjoyed the episode. If what you heard moved you, please reach out to that organization and do what you can to help. If you like and appreciate what we're doing to support local nonprofits, please give us a positive review, subscribe, and share. If you're a nonprofit with an interest in participating in an episode, you can reach me at jeff@hearmenowstudio.com. If you have a need for the services or products our sponsors offer, please reach out to them. CapTrust, fiduciary advice for endowments and foundations, Runyon Saltzman Incorporated, RSE, marketing, advertising, and public relations creating integrated communications committed to improving lives, and Western Health Advantage, a full-service healthcare plan for individuals, employer groups, and families. The Nonprofit Podcast Network is a production of, is recorded at, and edited by Hear Me Now Studio.